In this lecture, we will discuss premature junctional contractions, including its origin, mechanism, and EKG features. Premature junctional contractions, or PJCs, are beats that occur earlier than expected from an ectopic focus within the AV junction. The AV junction is typically defined as all of the complex of the AV node, okay, and the bundle of His. So if you look here, we can see this green right here. That's where our impulse is originating from. There's our AV node, okay, and our His bundle right below it. We consider this area the AV junction. So that's where our impulse is arising from. And notice how it's spreading both retrogradely to the atria and then anterogradely to the ventricles. In general, premature junctional beats are less common than premature atrial or ventricular beats, and they often appear sporadically, although they can occur in a regular grouped pattern such as supraventricular bigeminy or trigeminy. Okay, bigeminy is when they occur every other, and then trigeminy is when you have one and then it's occurring every third beat would be the premature junctional contraction. So why do these ectopic beats come about? Well, there are groups of pacemaker cells throughout the conduction system that are capable of spontaneous depolarization, just like the sinus node. The intrinsic rate of depolarization of these pacemaker cells decreases from the top to bottom along the conduction system. That is the fastest in the sinus node to the slowest in the ventricles. And the general rule is that the fastest pacemaker controls the heart. So generally the sinus node, okay, so let's just review this. Our sinus node that sits here tends to be has the fastest intrinsic rate and tends to be our default pacemaker of the heart, okay? However, if there's somewhere else, and in this case maybe it's the AV node, if it fires faster than the sinus node, then it starts to take over the pacemaking function, okay? So generally the sinus node has the fastest intrinsic rate. As we move lower to the atria, the atriomyocytes, to the AV junction, the His bundle, to the bundle branches, you can see that eventually it gets slower as we move down. And remember, the general rule is that the fastest pacemaker controls the heart, okay? Now, normally these ectopic impulses are more like secondary pacemakers that are suppressed by the more rapid impulses that originate from above them. However, if an ectopic focus depolarizes early enough, that is before the arrival of the next impulse, it may capture the ventricles, producing a premature contraction. These premature contractions, or ectopics, are then classified based on their origin. For instance, a premature ectopic beat originating from the atria is called a premature atrial contraction, or PAC. A premature ectopic beat that originates from the AV junction is called a premature junctional contraction, or PJC, as we see here. And then if a premature ectopic beat originates from the ventricles, we call this a premature ventricular contraction, or PVC. Now, these premature contractions are likely manifestations of unusual irritability of automatic pacemaker cells in the junctional tissue, okay? A re-entry mechanism may also play a role here. Now, our focus here is the premature junctional contractions, so those ectopic beats that are arising from our AV junction. Okay, so what we're saying here is that our AV junction here is firing before the impulse from the sinus node makes it to that AV node. Okay, so it's just firing early, and because of that, it's setting and becoming the pacemaker of the heart. So what about the EKG? What can we see? Well, in general, if you look at an EKG and you see QRS complexes that are regular and narrow, which denotes a supraventricular rhythm, and P waves that are difficult to make out, then you're likely dealing with some sort of junctional or nodal rhythm or beat, okay? Junctional meaning this AV junction, and nodal the AV node, okay? And if you see this sort of configuration in a beat that occurs earlier than you would expect, then we call that a premature junctional contraction, okay? So if you look here, notice we have a P wave, a QRS complex, and then our T wave, okay? So we have one cycle, then we have the next one occurring, a P wave, QRS complex, and then our T wave. And then all of a sudden we have a beat that comes earlier than expected, and this is our premature junctional contraction. Notice that there's no P wave that we can make out here, okay? And also that it's coming earlier than expected. So this is our normal R to R interval from one R wave to the next, okay? And the next R wave should occur here, although it's coming earlier than expected. All right, so this is our premature junctional contraction that we see here, and notice that there's a narrow QRS complex. Let's just erase that so you can see it. We have a narrow QRS complex that's similar to what we see in the one that comes before, okay? So again, all we're seeing here is that the rhythm is originating from within that AV junction right in this area. Okay, so everything below the ventricles is still occurring normally. So that's the general overview. Now let's look at this in a little more detail. So we said that these premature junctional contractions arise from the AV junction, and therefore activation below that region, that is activation of the ventricles, will typically be normal. In other words, there is normal antegrade conduction of the impulse down the normal electrical conduction system of the ventricles, and thus normal interventricular conduction. And as a result, the QRS complexes will be identical to the underlying rhythm's QRS complexes. And we said that typically normal and narrow. We were just talking about that, where you have these normal QRS complexes that are even seen here in the PJC. All right, so if you can just look at them, notice how they're all narrow throughout, okay? Because once this conducts from this area and conducts downwards or antegradely to depolarize the ventricles, everything down there is still normal, okay? So there's also retrograde conduction to depolarize the atria when it goes backwards, okay? So it's starting here, it's going forward antegradely to depolarize the ventricles, but it's also going retrogradely to depolarize the atria. Okay, and because we have both ventricular and atrial depolarization happening nearly simultaneously, okay, so it's originating from here, going down and also up at almost the same time, the QRS complex and the P wave will appear together. And depending whether the impulse originates high, mid-level, or low within the AV node, we can see the P wave at different areas relative to the QRS complex. For example, at times, the P wave may be buried within the QRS complex. As we saw here, we couldn't make out our P wave, okay? And then at other times, you may actually see the P wave occur before or after, okay? So that means we can have an antegrade or retrograde P wave. An antegrade P wave would be simply a P wave that appears before the QRS complex, while a retrograde P wave is one that would appear after the QRS complex, okay? So let's just take a look at that. So if we had a P wave, okay, we're saying that the one here is buried within, so we can't make it out, meaning that both antegrade and retrograde conduction is happening at the same time. It's buried within this complex. Now let's say that we have a case in which we're still starting at the same area, but maybe we're higher up here, so the atria are depolarizing before the ventricles, okay, slightly before, so the P wave may come right before our PJC. We may see an inverted P wave right before it that occurs, okay. Now at other times it may be low in that AV junction, so maybe it's down here. So in this case, maybe the ventricles depolarize before the atria. And in that case, we may see what's called a retrograde P wave, one that's coming after the QRS complex, okay? Now, as previously mentioned, both atrial and ventricular depolarization occur nearly simultaneously. And because AV nodal conduction makes up the majority of the PR interval, we will end up having a very short PR interval, or at least less than normal. And sometimes it could be even absent. This is due to the fact that the impulse is originating from within the AV junction. In addition, atrial depolarization occurs in a retrograde fashion. And as a result, we will see an abnormal P wave axis as we drawn here. Instead of the mean electrical P wave axis heading leftward and inferiorly, giving us upright P waves in the inferior leads, like in sinus rhythm, we will instead have the P wave axis going in the opposite direction in the frontal plane, leading to an inverted P waves in leads 2, 3, and AVF, those inferior leads, and upright P waves in leads AVR. That is, if we're able to even make out the P waves. Remember, sometimes they can be buried within the QRS complex if they both occur simultaneously. That's atrial and ventricular depolarization, okay? So again, if we just look here at our axis, we have a normal P wave is between 0 and positive 75 degrees. So where this red arrow is pointing, okay? That's when it's originating from our sinus node, it's heading that way. Now, in this case, we have it originating from our AV junction, okay, in this region, and it's going to go backwards to depolarize the atria. Remember, the P wave represents atrial depolarization, and because it's heading backwards, imagine it going in the opposite direction, okay, and because of that, where our leads, here's lead 2, okay, lead 3, lead AVF, our inferior leads, and then we have lead AVR. So notice now we have this vector that's heading away from those leads, so it would be negative in these inferior leads, and it'll be heading towards AVR, and that's why we tend to see a positive upright P wave in those leads if we actually do see a P wave. Now, just as a side note, what if you had a beat with a retrograde P wave but a normal PR interval? Well, that is actually considered to be a low atrial beat. It suggests that the ectopic focus is located in the low atrium, producing retrograde conduction through the atrium and normal delay at the AV node. And this is a controversial, and some suggest that the surface EKG cannot tell you with certainty where the ectopic focus is actually located. So just so you understand what I'm talking about, what we're saying is if we had a beat that occurs low here in the atria, but not actually here within the AV node, you may actually have a similar appearance where it would conduct backwards. So you would see those retrograde or inverted P waves in the inferior leads. However, you would have a normal PR interval. Okay, it might be short, but still within that 120 to 200 milliseconds range, because it still has that normal physiologic delay that it encounters at the AV node. All right, so that's just a little extra, but hopefully that makes sense. Okay, so now back to our premature junctional beats. So because the beat occurs sooner than expected, the R to R interval will be shorter than you would usually see in sinus rhythm. Okay, so we showed that earlier with one R wave to the next R wave, and then our next R wave should occur here, but we see it occurring earlier. Okay, so we saw that. So that's a shorter R to R interval that we saw there. And if the sinus node then decides to fire, so we have our sinus node, premature junctional beat, and then if the sinus node decides to fire, okay, and reaches the AV node before the AV junctional pacemaker fires an impulse, then the sinus rhythm will return, maintaining that normal R to R intervals, okay? And we call this a compensatory pause because the beat following the premature beat occurs when it normally should. That is, it compensates for the premature beat and does not affect the overall timing of the beats that follow. Okay, so let's just review this. So sometimes people have trouble with this, but so what we're saying is we have this sinus beat, premature beat, and then a sinus beat, okay? And that's because the sinus beat occurred before the premature or the AV junction decided to fire. So in terms of compensatory pause, remember our normal R to R interval is here, okay? And our next R wave should occur at this be here, but it doesn't. It comes earlier, okay? However, the next one does come on time. It comes when it should. So if you were to look at this, imagine this is one R to R interval. From this point to this point, this would be two R to R intervals, okay? So it's occurring when it normally should. It misses this one, it comes earlier, but then it occurs at the one that should follow. So we call this a compensatory pause, and it takes into account that premature beat. Now, sometimes premature junctional contractions that arrive early in the cycle may be conducted aberrantly, often manifesting with a right bundle branch block morphology. Okay, and that tends to be because the right bundle branch tends to have a longer refractory period. Okay. All right, so hopefully this is all making sense. Let's briefly go through our chart before we end here. So again, this premature junctional beat is an early beat originating from an ectopic focus within that AV junction. Remember, there's anterograde conduction to the ventricles as well as retrograde conduction to the atria. Remember, the general rule is that the fastest pacemaker controls the heart, and in this case, it's coming from our AV junction. The mechanism tends to be from an irritability of automatic pacemaker cells in the junctional tissue. Okay, there's also a possibility of some reentry cycle. All right, but again, that's the main one, this irritability of one of those cells. There's that compensatory pause that we just discussed. The regularity is going to be irregular, obviously, because we have this that's breaking up our regular rhythm. Okay, the rate really depends on the underlying rhythm, what's going on. Now the P waves, there could be either no P wave if it's buried within the QRS. It could be antegrade if it occurs before. Remember, if the atria depolarize a little earlier. And then it could be retrograde if it occurs a little later. Now we said there's going to be an abnormal axis because it's changing the direction, right? Now we're almost going in the opposite direction, so we can see inverted P waves in 2-3 in AVF and upright P waves in AVR. Remember, the P to QRS ratio, it may be even absent. There may be none if we don't see a P wave, or it could be 1-to-1 if we have an antegrade or retrograde P wave present. All right. The PR interval, again, there could be no P wave or no PR interval if it's buried within the QRS complex. It could be short or it could be retrograde. However, you should really note that the presence of this PR interval does not mean that the atria are stimulating the ventricles. Okay. In other words, Because you see that PR interval, it doesn't mean that the atria are coming this way and heading down through the ventricles. Instead, you have the atria being stimulated retrogradely and the antegrade conduction coming from the AV junction. Now, in terms of the QRS interval, we said that it should be normal and similar to the underlying rhythm. Okay. In terms of grouping, there's often no grouping, but remember, you can possibly see bigeminy or trigeminy, and there should be no dropped beats. Well, that's the end of this lecture. We discussed premature junctional contraction, including its origin, mechanism, and EKG features. I hope you learned something.